Thank you so much for keeping it Citizen Television and for joining us. In case you're just joining us on the show this morning, it is Daybreak. Wednesday it is. Health and lifestyle begins right now. And this morning our focus is going to be on our young population, but in general also we'll be looking at the bigger picture on the burden of HIV and AIDS in our country, and also just using this opportunity to talk about the triple threat challenges that have really taken us as a country by a big challenge in terms of investment, in terms of awareness, and in terms of what needs to be done to be able to address the triple threat that is now threatening the future of young people in our country. Kenya is still ranking among the top 10 countries, that is globally, when it comes to the HIV burden. We actually position 8, if my numbers are right, coming slightly below countries like Tanzania, Zambia, Uganda, and Nigeria. Nigeria has actually hit the 2 million mark, but we are high up there. And joining me to talk about this global burden and how Kenya is taking a hit of it and what strategies have been put in place to be able to address the crisis is none other than the acting CEO of the National Syndemic Diseases Control Council, Dr. Douglas Bosire. Asante sana for creating time for us this morning.
Thank you very much, Safin, and thank you for having me.
Karibu sana.
Yes, thank you.
We are talking about, I was looking at the numbers yesterday, Daktari, in terms of new infections, 54 new infections every week and 22 AIDS-related deaths every week. That is just the numbers that I came across from what your council shared. Should we be concerned about the HIV burden in Kenya as we speak this particular morning?
Thank you very much, Safin. And first of all, I want to really take this opportunity to thank Citizen for having us this morning on this important program that talks about our lifestyle and our health. It's a contemporary issue. And HIV is an epidemic that is one of the greatest public health challenges that humanity has witnessed. Since the first case was detected in Kenya in the year 1984, we have lost close to 2 million Kenyans due to AIDS-related illnesses. However, most importantly is also to recognize the remarkable progress that the country has made in the response towards this epidemic. If you look back, for example, just only 2 decades ago, in the year 2005, we had about 94,000 new HIV infections per year in this country. Last year in 2024, we had 19,991 new HIV infections. In the same period, in the year 2005, we had about 110,000 deaths due to HIV or AIDS-related illnesses. However, if you look at the year 2024, we recorded about 21,007 deaths. Those are remarkable progresses, almost 80% reduction. If you look at the prevalence of mother-to-child transmission. In the year the incidence of mother-to-child transmission, if you look at the year 2005, almost 1 out of every 3 mothers who are living with the virus passed the virus to their children. Because
1 out of every 3.
1 out of every 3. It was about 35%. But if you look at the year 2024, it is 9 out of 100. Who are passing the virus to their children. So
that's a reduction?
It's a significant reduction from 35% to 9%, almost 4 times reduction. So, however, the concern that we have when we granulate the data, when we study the data deeper, we realize that there are some sections of the population that are being left behind, and some which are at higher risk who need a special focus. One, when you look at our children, you know, we normally look at a cascade that 95% of the Kenyans who have HIV should know their status. 95% of the Kenyans who know their status should be on treatment. 95% of the Kenyans who are on treatment should be virally suppressed. Currently, 97% of Kenyans, general population, adults especially, know their status.
So we've surpassed.
Yes, 97%. Exactly, 97% know their status. The challenge comes to suppression, where we have a population of about 79% of those who are on treatment who are suppressed. However, when you compare that,
access to treatment.
Yes, I'm coming to that. Access. When you look at the same and compare it with the children, you find that you have left the children a little bit behind. Whereas it's 97% of the adults above 15 plus years. In HIV, we define adults as 15 plus. So when you compare that adults, 97% of the adults know their HIV status. It's only 86% of children between 0 and 14 who currently know their status. When you look at the last 95, which is the most important, viral suppression. Because if you are virally suppressed, then it means you cannot transmit the virus to a partner or to anybody that you are exposed to. It's 66% of children between 0 and 14 years who are virally suppressed.
So that's way below.
It's way below the adult. And below the adults. And what that tells us is that we have left children behind, and therefore you expect that we will have disproportionate rates of mortality among these population cohort. And that's why His Excellency the President has directed that we spare no effort to end AIDS in children by the year 2027. It's actually a commitment.
All right.
Yes.
Dr. Before we get to what needs to be done for us to get to even the vision that the head of state has for the country when it comes to dealing with this pandemic, you've mentioned quite a crucial population, that's children. And today our focus mainly is on the young adults. And you're saying that quite a significant number of children who have this virus don't know their status. Is that a ticking time bomb? Because right now we are talking about the age of sexual debut being way low, and talking about that very same population not knowing their status. Could we be having incidences where young people are infecting each other without knowing that this is happening?
All right, let's talk about that for a little while. Interestingly, of the 19,991 new HIV infections that occurred in the year 2024, 41% of those that were above 15 years, 41% occurred amongst adolescents and young people who were aged between 15 and 24. 74% of the new HIV infection occurred among those who were aged between 15 and 34. That is a young age bracket. And Safin, I don't know if you were there in the 90s, when the villages and the households in the high-burden counties of Homa Bay, of Kisumu, of Siaya, of Migori were dotted with graves, were dotted with houses that had been deserted because of departure of loved ones. Children became orphans. And the messages that we had out here were messages that AIDS kills. There were huge billboards. It was a death sentence. There were huge billboards all over town, all over the, whichever part of this country that you traversed. However, because of the investment that the government has done, together with our development partners globally, we have a robust treatment program that has put almost the entire cohort of 1.3 million people who are living with HIV on treatment. What that happens, when that happens, is that anyone living with HIV is able to live a lifelong, which is high quality, which is productive, and they can even have children and a family without infecting their partner or without passing the virus to their children. So anybody today who has HIV looks like me, looks like you. You cannot tell from the face. So the young population.
Which is also a danger.
Yes, exactly. It can be, we can be victims of our own success because of that. And as a result, these children, these young people we are talking about today, so somebody who's aged 25 years today was born in 2000. They really never saw what we call advanced HIV disease. They never saw those, emaciated, frames of people who were put in those billboards as a way of scaring and pushing behavioral change. So today they are more worried about pregnancies they are more worried than HIV.
There's a generational gap between what HIV used to look then and what HIV looks now. If you talk to the now generation about what HIV used to look then, they will be wondering what you're talking about, because they don't see those people you're describing.
Exactly. I've been to sessions where a young person stands up and says, I fear cancer more than HIV, because they think that HIV, you can live with it. However, without taking the antiretroviral drugs on a daily basis, then one risks developing full-blown AIDS or advanced HIV disease, as we call it. It costs the government an average of about 40,000 shillings every year to keep a person living with HIV on treatment.
40,000.
40,000.
Per person or?
Per person.
Per person.
Yes. So if you look at the
1.3 million.
Yes, the need is about 28 billion shillings per year. That 28 billion shillings is a lot of money that can go towards, several projects. The other day, just the day before yesterday, we were in Busia with the Kenya Women Senators Association. In Busia, the senators are having women mashinani, Senate mashinani this week. So they invited us to go and showcase them an experiential learning on ending the triple threat. And we noticed that in Busia, there are about, I'm just picking Busia as a small county and as a county that we have had a visit to the day before yesterday. There are 43,155 people who are living with HIV. If you calculate 43,155 times 40,000, it comes about 1.7 billion. The total budget of Busia is about 9 billion per year. So they would have, in case the government ceases to support, the national government ceases to support medication, and our partners also withdraw, because right now we are facing a time of uncertainty in funding from the traditional partners who have been funding our response, particularly the American government. We all know what happened in January this year when you had the stop work orders.
Donor funding.
Yeah, exactly. Because countries now are looking inward. The United States is saying America first. So if you look at the risk of continuing operating with an open tap, mopping the room with the tap running, then it will overwhelm the healthcare system. And for sustainability, what we are saying is the people who are living with the virus should be supported. They should get integrated into His Excellency's agenda for universal health coverage under the social health authority schemes, so that their treatment is assured. And at the same time, we must focus on prevention. We must make sure that we stop any new case getting infected, because it is not only a financial cost to the country, it also has a demographic loss, demographic dividend loss to the country, to the family, to the society, to the individual. I want to remind Kenyans that once you get the HIV virus, you live with that virus for life. The technologies for making you free of that virus are way out of reach of the common mwananchi, and they are not 100% proven effective.
Before we get into what really happens, first of all, I like that strategy of dealing with this tree on both top and bottom, like in terms of investing in prevention, but at the same time, trying to look at programs that can help those who are already infected get treatment and achieve their viral suppression targets, so that we are sort of like dealing with the problem on both sides.
True.
But then again, let's talk about the young population for a little bit. You said something about 74% of the new infections actually are between the people between the ages of 15 and 34.
Yes, of the adult new infections. Yes. Let's
talk about the driving factors. In your assessment as a council, what do you find out, on the ground in terms of what is leading to the high numbers of infection, especially among the youth? And this has been the script year in, year out. It doesn't seem like it's changing. Every time the numbers are out, we see the big headlines on the young people. What seems to be the problem?
Yeah, thank you very much. We also must recognize that the young people now form a bulk of the population of the country.
Yeah.
Almost 59% of Kenyans are aged below 24 years. So that's a very huge cohort. And it tells you that is a bracket then that probably more infections will occur. However, when you look at the knowledge levels and of this population cohort around the issue of HIV prevention, it is wanting. The Kenya Demographic Health Survey of 2022 informed us that the knowledge levels of these young people is about 54-55%. Between female and male. So it's a very low, rate of knowledge level. And no wonder it is depicted or it's expressed even in the number of unwanted pregnancies among this young population that we see. And right now we are focusing mainly on even the younger population, the adolescents themselves, between 10 and 19, because the transition between childhood and adulthood that period is called adolescence, and that's a period where one affirms their beliefs, their cultures, their ethos, their ethics, and their morality. So it's a very important period for us to inculcate holistic virtues of decision making, so that as these young people transit from being under the care of their parents to being on their own, then they're able to make judicious decisions. Last year alone, Safin, unfortunately we recorded about 240,000 cases of adolescent pregnancies. Children, young children, aged between 10 and 19, who should otherwise be in school, who should be dreaming of becoming Safin when they see you on this national.
Young mothers,
but now they're young mothers. They're young mothers. We have gone to counties where you have a 26-year-old who is a grandmother, having fallen pregnant at 13. And the girl, because of the cycle of poverty, the daughter also fell pregnant at the same age. So at 26, she's already a grandmother. And once this happens, it becomes extremely difficult for you to pull yourself out of the cycle of poverty and to live a meaningful life. You need a very strong family support system, which unfortunately we are losing every day. And so this 660 pregnancies that are recorded per day is testimony and evidence to us that there's a lot of unprotected sex that is going on among these young people. And that is why we came up with this, what you talked about earlier, the initiative to end the triple threat.
Yes. You know, as you're talking, Daktari, I'm having a lot of questions, and you'll pardon me for interrupting.
It's okay,
quite a bit.
It's okay.
In terms of correlation, first of all, let's begin there, between the teenage pregnancies, HIV, and now we bring in the sexual and gender-based violence among the adolescents. What's the correlation, and what inspired, an approach that really targets these three challenges together? Yeah.
Thank you very much. One of the facts in Kenya, sex with a girl who is aged below 18 is actually a criminal offense, and it's called defilement. And defilement is a form of sexual and gender-based violence. Of the 47,000 cases of sexual and gender-based violence that were recorded last year, almost 17,000 were among children aged between 10 and 17. 37%. 37%. And those are the ones who reported to the health facilities. So
there could be more.
There are more. We do know for sure that there is a lot of sexual and gender-based violence, and generally gender-based violence that is taking place without being reported. And nowadays it's not only affecting the girl child, but also the boy child. So when a child of 11 years, of 12 years, is under my power, is under my decision-making authority, because I have the money, I have the agency, I'm the one to dictate how she behaves. Whether if she wants diapers, for example, if she wants sanitary pads, and she's desperate for it because a father or a mother has not provided or she's an orphan, or she's an indigent, then she becomes vulnerable. She's carried, she gets a man dressed as good as I am, looks at me, says this one cannot, for heaven's sake, cannot be having HIV. I give her 200 shillings, sometimes 50 shillings. We have the case of sex for pads, and I sleep with her. And this is happening. Again, just to comment about what you talked about earlier, we were told by the principal of St. James Kwangamor, where we were the day before yesterday, that out of the cases that he currently has of adolescent pregnancies, some of them are, anecdotally associated with colleagues of these students, Romeo and Juliet, the kids, they're in the same peer-to-peer,
or sort of like almost age mates.
Yeah, like almost age mates, but also from our boda riders, because a parent, send the boda rider to take the kid to school, drop the kid back to school, and probably does not provide sufficient fare, or the boda ride, not all of them, a few mistaken cases, decide to take advantage. So this is happening, and these children become unduly subjected to this kind of abuse because they do not have negotiating power. All
right. Doctor, aside from the abuse that happens, which is very evident and true, there's also the voluntary, engagement in sex at a young age. Probably let's talk about currently where do we stand when it comes to the mean age of, sexual debut. Has it gone down? Is it higher? At what age, like on an average basis, are young people engaging in sex? And is that a concern also for you as a council and as stakeholders who are dealing with this in a preventive sort of approach?
Yes, I think that's very important, because early sexual debut predisposes one to this kind of infections than delayed sexual debut. Yeah. The median age varies between counties, but it should be between 14 and 16, thereabout. Okay. That's the median age of sexual debut in this country. And you find that at that age, decision-making, even knowledge levels are very low. Therefore, there is a lot of power imbalance between these two, and worse still is where we have transactional and transgenerational sex, where there's a huge age disparity between the man and the girl. The man is aged maybe 30, the girl is aged 15, is aged 16. The girl absolutely has no decision-making capacity.
There's a lot of power play.
There's a lot of power play. There's a lot of power play. And remember, for us from the HIV space, once you have accidentally been exposed to a potential HIV infection incident, you are supposed to seek services within 72 hours so that you can be put on what we call post-exposure prophylaxis. If you are not put on post-exposure prophylaxis within that period, then the risk of developing the virus anchoring itself in your body and becoming a person living with HIV is extremely high. So time is of essence. And that is why in this agenda, known as End the Triple Threat, we are saying it is a whole society approach. It's not a whole government approach, but a whole society approach, where the community health promoters, where the parents, where the religious leaders, where the teachers in class can actually see the telltale signals that, Safin, today there's a problem, and interact. Most of us parents, because of our busy schedules, we have actually forgotten to have those intimate moments with our children. By the time, Safin, we get home, it's 10 o'clock. The kids are asleep, and they wake up before we wake up. They wake up at 5. So in a day, you really don't have time. But the people, these children are spending most of the time in school, with their teachers. And that's why the competency-based education system has come out very strongly in terms of life skills and health education, so that these children they are not only, taught to name what's a penis, what's a vagina, what are breasts, but they are also taught what are the functions of those organs and at what stage those organs can cause you harm.
So age-appropriate sex begins at an early age.
Exactly. Yes, competency-based education, age-appropriate sex education is starting at 5 years, at grade 5, which is an improvement from what it was before. And in fact, I engage with many teachers, and they're telling me they have seen an improvement. And one of the programs also that we have is, as a council, is to engage with the class teachers and the caregivers in school and the matrons to reduce the amount of stigma that learners who are living with HIV face.
All right. You talked about a holistic approach and this being a society issue, not just a health issue that needs to be addressed with health strategies. It's sort of like, it's more of a moral issue, a spiritual issue also, if you ask.
So sure.
But then when you get to the beliefs and the things that people even hold dear when it comes to, for example, a topic like sex education, for instance. The church probably would come with the narrative of abstinence, which many people, again, would counter and say is not practical. Others would say, because the median age of sexual debut has come down, let's provide family planning to our children. Others will counter that narrative, and they will give their own opinions as to why that should not be the case. So how do you amalgamate all this, varying opinions and feelings so that you come up with what is a win-win for the religious sector, for the health sector, what the Constitution provides, what the youth and the Gen Zs also want? What happens to come up with what will work?
Yeah, that's a very good question, Safin. And it's a progress. It's not an event. It's a process. If you look at the fact that if you look back in the 1990s, somebody who was suspected to be living with HIV or had AIDS, because AIDS was common in those days, was treated with a lot of stigma in society, was a pariah, was an outcast, and therefore was not considered as a human being who should be supported. But look now, we have heroes and heroines who have come out and opened up and told the public that I am a teacher living with the virus. I've lived with the virus for 20, 25 years, 30 years. And I decided to have a conversation. In fact, there is one teacher who told us that she decided, when she was diagnosed, she decided to have a conversation between her and the virus. And tell the virus, you are not going to, you are not going to kill me. You talk to yourself. Sometimes I do also have conversations with myself. I don't know if you do.
All of us.
Yes. Unajita mkutano. So after umejita mkutano, then you are able to make rational decisions. So if when we are looking at the progress also that you have made with the various groups that have been opposing what initially was is known as comprehensive sexuality education. The religious groups, the other social groups, there are many. By the time we are having this health education and life skills in the competency-based education, that's a mark of a step that we are making. So we continue engaging with the religious leaders. In fact, we have national thematic working groups that engage with the faith sector, where we come together and say, hey, look here, for sure, we can't keep on burying our heads in the sand when you're having 660 cases of adolescent pregnancies per day in this country.
That's alarming.
That's alarming.
Those are futures that are,
are threatened. Dreams that are shattered. And even the health of these girls can never be the same again, both physically and mentally.
And we lose some.
Exactly.
Their bodies are not ready to really...
To bear children, yes. So it is not, it's no longer a question of morality. To me, it's a question of what is it that is the right thing to do. And the right thing to do is to give these young people education, to give them information, to give them knowledge, so the young people can make decisions that are right. Number two, if these young people, if, for example, you as a parent, you know that you are a 17-year-old girl is now in college, and probably she is exposed to sexual activity, sit down with her also, have a discussion with her, or your boy, sit down with them and tell them about the opportunities for protection that exist, the options, right? You can abstain, you can use protection. There are many options even of prevention now that we have. We are only not talking about condoms, but we are talking about other options. Although the other options also have their challenges. Yeah, because yes, you can use what we call a pre-exposure prophylaxis. But that pre-exposure prophylaxis is not for the common public. It's for those ones who engage in high-risk sexual activity. We are talking about female sex workers. We are talking about men who have sex with men. We are talking about people who inject drugs. We are talking about transgender people. So it's given conditions. It's not just for everybody. It's not just for everybody, and it's not recommended for everybody because it is, you know, if you are not having high-risk sex, then it will be detrimental and expensive to us as a nation to keep you on prep for those periods of time, and yet you are not a high-risk individual. However, there is progress that is being done on that end, which then will make it more affordable, not only from the government, but also even from the individuals who can afford to buy and utilize these new innovations. For example, a company called Gilead the other day launched an injectable pre-exposure prophylaxis. It's called lenacapavir. That drug, the list price in the US right now is $28,000 for 2 injections per year. That's about 3.6 million Kenya shillings. So how many can afford that? You and I cannot afford. Even me, I cannot afford. I'm an acting CEO, I cannot afford that. 3.6 million shillings per year. However, Kenya has been selected on the Global Fund program as one of the early adapters. In fact, we are very lucky, and we really thank our Cabinet Secretary, Honorable Aden Duale, for picking it up and running with it. We are one of the early adapter countries. There are 9 of them, which is going to benefit from early introduction of lenacapavir. And by the program that has been made, the drug is going to be available free of charge to a certain number of key populations. The key populations I'm talking about, okay, let me just explain this. The general population, the prevalence of HIV in the general population right now is about 3%. But we have certain population groups where the prevalence is much higher. For example, the prevalence among female sex workers is 27%. It's almost 10 times higher than the general population. The prevalence of HIV among men who have sex with men is about 19%. The prevalence of HIV among transgender people is 22%. The prevalence of HIV among people who inject drugs is about 10%. So they are at a higher... Exactly. Right. And these are the ones who are going to be prioritized, so that, because these populations live within the general population. So any spike among that special group, or rather priority group, let me not call them special group, priority group, will inadvertently lead to an increase in the general population. So those ones will are part of that program. However, global negotiations have also taken place, which Kenya has participated in, to bring down the cost to the common mwananchi, so that we can have what we call a total market approach. to reduce the cost to about $40 for the 2 injection dose per year, which is about 6,000 shillings, which will be affordable. And within the next, maybe 1.5 years, by 2027, those solutions will be available locally, and it presents a great opportunity towards ending new HIV infections.
All right.
Yes.
Apart from what the future looks like, and I like how futuristic you are about, where we are going and what's already happening right now. You talked about, we've made a lot of progress in meeting the 95-95-95 cascade. Probably you can also take us in depth on what has led to this, progress that we are experiencing today in terms of even just lessening the burden of HIV in the country. What has worked that needs to be sustained, and what change of strategy do we need to end HIV? Is it by 2030?
By 2030?
Yeah.
Yeah, Kenya is a signatory to the Sustainable Development Goals. And one of those targets is to end AIDS as a public health threat by 2030. We do know the virus will still be with us in 2030, but we are ending AIDS as a public health threat by 2030. And that is possible, that is feasible, if we can flatten this curve fast enough. The treatment program that Kenya robustly launched in the late 1990s and early 2000s has worked. Because when you're on treatment and you are virally suppressed, then you do not transmit the virus
to others.
So treatment then becomes also prevention in that aspect. And that is why it's concerning to us when people interrupt treatment. And this is very common, particularly amongst men. And sometimes among mothers who are pregnant or who are breastfeeding. In fact, last year, of the cases of mother-to-child transmission that we had, which I've told you the rate was about 9.3%. 2/3 of those mother-to-child infections were due to either not being on treatment at all or dropping off treatment. So we know that treatment works. That's why we are encouraging each and every one of us to be tested and to know their status. And men in particular, we are concerned about men. Why? Among boys and men aged 10 plus in the year 2023, of all the total tests that were done, only 27% were among boys and men.
So men don't want to get tested? Men,
I wait for you, if you are my spouse, to go to the ANC clinic.
First.
And you come back with a result that you are negative. And I go and sit with my boys, I go to the Changaden in the village, the Bosaden, and I tell them now I'm okay, I'm a man, I'm okay.
You assume that you also
I assume that I'm okay, yeah, but not knowing, not remembering that they are discordant couples. Yeah, one can have the virus and the other one does not have the virus. Number 2 is the interventions that have been put in ensuring access to services and access to treatment, bringing the services closer to the people. Right now, when you go around the country, almost all the registered public health facilities and even the ones in private and the faith-based, the registered pharmacies, you can actually go there and get your drug rations, so you do not have to go and take the long queues in the hospitals to wait for your turn. Number 3 is the element of managing the epidemic among the key population. In 2011, the key population that I've talked about, and I've named those groups, contributed to almost 33% of the new HIV infections. 33%. Because of the programming that we have done. And that is why sometimes we make an appeal. Article 43 of the Constitution of Kenya entitles everyone to the highest attainable standards of care, of health care, including emergency health services. Now, you find that you have a group of, for example, men who have sex with men. And we do know that the risk of transmission through anal sex is much, much higher than through heterosexual sex. And apart from the information and the education that we give, there are other measures that reduce the chances of them infecting one another. So for us, from a health service perspective, it's to give them that information and give them the tools that can reduce chances of them spreading the infections among themselves and back onto the general public. You'll be surprised that a very good proportion of the men who have sex with men are also engaged in heterosexual relationships. They have families, they have wives.
Also, they are married.
They are married.
They have families.
Exactly, exactly.
So the risk is also transferred.
It's transferred to the families, to the general population. Yeah, so they need to be particularly planned for. Another group that is interesting that we have to plan for is the group of people who inject drugs. You know, if you go to the drug dens of Mombasa there, and Nairobi also, and Nakuru and Eldoret, now they are coming up everywhere. If, for example, I do not have sufficient money to go and buy my dose of cocaine this morning, and I've started having, those withdrawal symptoms. What I do is that I come with the same syringe. You have taken your dose. You are high. I pull out some of your blood and inject myself so that I can have the high feeling. Yes.
Okay.
Yes.
Okay. And even sharing of the syringe.
Yes. That is direct. So your blood, my blood, or I use your drug to mix, your blood to mix, and then the sharing of the syringes. So what we have a program called needle syringe program, where we replace. Of course, we are also having a public education program on the other side to educate them on the dangers of drug, alcohol, and substance abuse, which we are doing with the other stakeholders, including NACADA. But at the same time, for those ones who have not yet been rehabilitated and cleaned up and weaned off, even through the methadone-assisted therapy programs that we're having. For those who are still, abusing or injecting, then you give them new, fresh syringes and needles so that they do not keep infecting each other. So these are special programs that we have done for the key population, which sometimes are misunderstood by society, which are sometimes misunderstood by people living within those areas, because they think that we are supporting, we are advocating, we are promoting. Giving it a green light. And giving it a green light. How do you address those concerns? Through multi-sectoral. Considering the different opinions that people have on these specific subjects that you've mentioned. That is why as NSDCC Safin, in each of the 47 counties, we have what we call multi-sectoral coordinating committees. Multi-sectoral coordinating committees are committees which bring actors, stakeholders, both from the government, state and non-state, and development partners and implementing partners. They are chaired by the county commissioner and co-chaired by the county executive committee member for health, and they include all the players who are important, and they can even opt if they want. So this is where, because the infections take place in the counties, and this is where the discussions happen. If there's a challenge, if there is a misunderstanding, if there is a certain group that needs to be brought on board and engaged and informed why these programs are important, that is where it happens. We don't wait for these instances to be scaled up to the national level, but we make sure that there are consistent daily and quarterly meetings, that engagements that are taking place, so that when there are hotspots, then they can be tackled and the issues can be resolved in advance. We have had a number of counties where, particularly from cultural perspectives, from religious perspectives, they are not comfortable with having these kind of facilities in their neighborhoods, but we have engaged, and that continuous engagement, that owning this response and saying it is your business, it is my business. It's not government's business alone, has really helped. Yes.
Another area that is quite familiar for many parents and caregivers is the area of teenage pregnancy. The numbers have gone down. From 2018, it was around 400,000. You just mentioned the figure of 240,000. This is the latest, the 2024 data, which is still high. Which is still high. So what has been done in that area as well to, first of all, reduce the numbers and also to make sure that it will be zero? Because we don't want underage girls, mothers in the future. So, Safin, you actually understand this subject very well. I must appreciate, because, you know, from the framing of the questions and the content, I really do appreciate, and I am happy that we have a champion, and among the others that we have in the media space for progressing this discussion. Because from where you sit, young people listen to you. When young people look at Safin, they see a role model. So we encourage you, and we are really grateful that you appreciate this challenge and you have these facts. Now, we are a couple of government agencies that are involved in this initiative of ending the triple threat. We, as a National Systemic Disease Control Council, the Ministry of Health, are charged with the responsibility of a National AIDS and STI Control Program, NASCOP. We are charged with the responsibility of ending AIDS as a public health threat by 2030. Now, when you go to the State Department of Planning, the National Council for Population and Development, NCPD, is charged with the responsibility of ending adolescent or teenage pregnancies by the year 2030. Still same SDG goals. If you go to the State Department for Gender, they have a mandate of ending GBV and all forms of sexual and gender-based violence as well. So what we did is we looked at it and the nexus between new HIV infections, adolescent pregnancies, which are signs of unprotected sex, and also sexual and gender-based violence are correlated. In fact, Safin, if I show you a map of Kenya and we have an overlay of these three, you will see where the balls of new HIV infections are huge. That is where we have huge boxes of sexual and gender-based violence, and we have big stars of adolescent pregnancies. So there's a direct nexus and a correlation. So we came together and said, let us break our silos. Let us stretch the shilling that NSPD has, that NSDCC has, and we work together. When you go and you are engaging your stakeholders on matters of ending adolescent pregnancies, engage them on matters of SGBV as well, engage them on matters of HIV. And that is what we are doing. So we, together with the counties, we actually developed a commitment plan, which is a commitment plan binding us as the duty bearers, as the government lead agencies, to coordinate and bring on board all the actors and stakeholders, including the UN bodies here in Kenya. In fact, tomorrow, our CS is going to be chairing a meeting of the UN joint program with the ambassadors and chiefs of missions here in Nairobi from donor countries, in a donor breakfast round table meeting around the issue of fundraising towards ending the triple threat in this country. Yes, which is part of the UN joint program cooperation framework with Kenya, because the UN joint program identified this as a priority. We through this multi-sectoral, intergovernmental, interministerial collaboration, we have been able to cascade and utilize the government opportunities that are there, both government and civil, that are there towards enhancing education and enhancing reduction of these numbers. For example, yesterday, our team was at the Embakasi Administration Police Training College. We are partnering with the Ministry of Interior, and we really thank the Ministry of Interior for that. We have said that we will use the assistant chiefs and the national government administrative officers, assistant chiefs, DCCs, ACCs, to cascade and to report and to enforce. Because defilement is a crime. So whoever is found defiling, they should not be subjected to kangaroo courts there in the villages.
where the chief is maybe given 1 or 2 goats, or the chief is a cousin of the perpetrator.
Tutaongea kifamilia.
And the life of a young girl, the life of a Safin is at stake. No, so we are taking advantage of the training program that the Interior Ministry is running with the chiefs and assistant chiefs. And yesterday alone, we sensitized about 3,500 assistant chiefs and chiefs at the Mbakasi AP Training College. What are we doing with this? We are working on a whole government, using a whole government approach, because we are not paying them any additional resources. We are just giving them information which is accurate, because there is also a way you pass information which should be uniform. We don't want somebody to go and stand in a baraza and say ukimwi unaua. That is wrong information. But you know, remember back then in the 1990s, that was the message. But the messaging now has changed. So we are also equipping them. We have actually come up with a curriculum. We have come up with an information package that we are giving them, that as you go, this is the information package. And these are the support lines that you can seek assistance from if you need technical assistance to come and run your barazas. Because each of these chiefs in this country and assistant chiefs holds about 2 barazas per month. Each baraza, assuming there are 10,000 of them, and each baraza is attended by about 50 people. So when you calculate, you find out that each month we can be able to reach 1 million Kenyans using the national government administrative officers who are on the ground, if not more, using our community health promoters, 107,000 of them, who have a responsibility of promoting health in households. Every month they should visit the households that have been allocated to them. We can actually do this. We can stop the dependency on the donor funds that we relied on in creating awareness and public health campaigns back in the day, which are now not available. And we have a country-owned response that then sees us 2030.
On that specific issue that you've mentioned, you say we can, and I believe also we can. But what is already happening? Because just recently, and you were even alluding to this earlier, we saw what happened with the US and the withdrawal of funding.
Yes.
And that big fear that was created as a result of the shrinking donor funding space. There was a demonstration about, you know, the lack of drugs, the shortages of protective material. We've had this narrative over time. What are we doing in terms of just taking care of our population and not looking outside when it comes to who then comes at our rescue when we need such materials, when we need such essential drugs?
Thank you, Safin. First of all, when we had these shocks from the announcements by our partners who have supported us for a very long time, and we must appreciate, the government, the ministry, you know, set up an emergency ministerial committee to look at what was the effect of these stop work orders, what was the effect of the defunding of some areas, and critical areas were identified. Critical areas of human resource for health, because we had some health workers who were affected by these changes. Critical areas in terms of the potential loss of funding for commodities, which did not happen. The PEFA program, or the American government program, is still supporting the commodities that they were supporting, and also the Global Fund is supporting. And also we had some disruptions of what we call our electronic medical records, our EMR, which the government has now taken up.
Did we suffer shortage of ARV?
No. There was no shortage of ARVs. There was no shortage of ARVs at all. What happened is that there is a dual distribution system. The commodities that are procured by Global Fund and by the government of Kenya are supplied through the Kenya Medical Supplies Authority, whereas the ones which are, you know, which we are supported by the Americans, are supplied through what we call Mission for Essential Drug Supplies. Okay. So when the stop work order came, the Mission of Essential Drug Supplies could not be able to deliver the commodities that they had in stock at that time because they did not have that authority. It was a stop work you stop work. You know, a message comes today to you from the MD of Royal Media telling you, Safin, stop that interview. You'll stop the interview. And then the rest will be resolved as time goes by. However, that was quickly resolved through the intervention again of the ministry.
So the drugs were there?
Yes, the drugs were there and they were distributed. So what was the challenge was that they would not distribute because of the stop work order. But that was very quickly resolved through engagements between the ministry, the Kenyan government and the American government, and that was resolved. So we really never had a shortage of commodities.
So what internal mechanisms are we putting in place to serve our population?
Yes.
Depending on donors?
Yes. First of all, we have to change the way business was being done before. It's a fact. Remember, when you used to go to most of these hospitals, they used to have what we call comprehensive care clinics, which are standalone comprehensive care clinics, known for that is a place of HIV patients.
All right.
Now, in this day and era, a 60-year-old or 50-year-old person living with HIV also has diabetes. The same person also has hypertension. The same person has other lifestyle and chronic illnesses that require them to seek holistic services. So we are saying we integrate. We are saying instead of you being attended to in the CCC, which is a standalone HIV care and treatment center, we integrate the services so that the HIV is considered as a chronic condition. And therefore, you are seen in the outpatient special clinics that currently you obtain.
All right.
If you are coming to pick your drug rations, there is no value of having a standalone pharmacy in the facility only for ARV drugs.
You can take all your drugs?
Yes, we have pharmacists who are trained. Exactly, we have pharmacists who are trained. Yes.
Thank you so much, Dr. Bosire.
Yes.
You know, when it comes to this topic, passion can make me...
I can see.
Thank you so much for
taking
time. That's the much time we had for this conversation.
That was very short.
Yeah, I tell you, I believe you've captured one or two in terms of tracking progress on ending the triple threat among the young population and also the general conversation around what the country has achieved in dealing with the HIV burden. But that's the time we had. Thank you so much for creating time to watch Daybreak this particular morning. Have a lovely day ahead.
Thank you.